Aisha. And we started this series with the transplant chapter, giving the applied immunology 1 month ago. And we are all waiting to hear the second part of the applied transplant immunology. But before we start, I would like to congratulate the transplant chapter of the Egyptian Society of Nephrology and Transplantation, because this week the guidelines of Egyptian guidelines on immunosuppression and transplantation has been published in the Arab Journal of Urology with great effort from the transplantation chapter of the Egyptian Society of Nephrology and Transplantation and our dear colleagues in the urology department, Dr. Ahmed and his colleagues, and many collaborators from Egypt, from different universities, shared and give their opinion before this publication. I think it will be a very good step forward, and we are waiting also to put more guidelines in the next 2 months with the transplant chapter group working on this. And now I leave. I'm of course honored to have co-chair Professor Ayman Rifai and Professor Ashraf Fouda, and Dr. Ayman now will chair the session.
Thank you very much, Professor Hani. I think we all enjoyed the first part of this lecture about the very hot and important topics in transplantation, which is the transplant immunology. We enjoyed the first part with Professor Ahmed Halawa, the consultant transplant surgeon and the associate professor at University of Liverpool. And we are waiting to have the case scenarios in the second part of this subject. And I invite Professor Halawa to start his presentation. Please, Professor Halawa.
Thank you very much for this nice introduction, and congratulations for the Egyptian guidelines in immunosuppression. It's been long waited, and I'm sure it will make, this will make a strong impact on the transplantation practice in Egypt. Well done, and hopefully looking forward to read more guidelines and more standardization of treatment in Egypt and in the Arab world. Part 2 today, applied transplant immunology, case-based discussion. Transplant immunology is like a deep ocean, has no bottom, and it's quite difficult to swim in the ocean. It looks like, I'm trying to learn immunology, but it looks like I'm learning how to learn immunology. So you will never get into the bottom of all facts. And this is something which is astonishing, is, it looks like is a gray area, and it looks like practice makes perfect. You have to practice it to learn, rather than learning from books. Today, I'm going to discuss basically DSA antibodies, HLA and non-HLA antibodies. And we'll give you our experience in 4 cases, because these 3 cases actually, 3 of them actually submitted for publication. And I would like to, debate with you, because no one will agree on a universal treatment, because nothing called the standard treatment when you deal with transplant immunology. Fine. So post-transplant DSA. So that, the objective of this lecture will discuss the preformed DSA class 1 and class 2, the novo DSA, non-DSA, complement fixing DSA, non-complement fixing DSA, DSA subclasses, and the practical application of all these confusing, topics in clinical scenarios. And at the end, hopefully we'll be able to discuss together what we could do better. To start with, all are bad. Whatever to say, whatever, pre-existing, de novo, non-DSA, this is a conclusion. So we can finish the lecture, by 2 slides, but all are bad. But some are worse than the others. The longevity of renal transplantation now is much better than before. So they will get sensitized. They live longer. The graft will fail. You have to retransplant them. So this is a fact. You have to deal with sensitized patients at some stage of your life. Graft can survive up to 40 years, eventually will fail. You need to retransplant. The retransplant could fail. You could put the 3rd kidney as well, and even the 4th. The maximum number I did is 4 kidneys in one patient. And this was over around 15 years' time. Correct me if I didn't get it, accurate, but it's actually over a long period of time. So DSA or non-DSA or non-HLA associated with worse prognosis compared to no antibodies. We agree on this. Associated with both acute cell-mediated and acute antibody-mediated rejection. Yes. Associated with chronic immunological damage. So as I mentioned, all of them are bad. And this is another conclusion you can make at the end of the lecture. But it's not that dark and gloomy as you think. And this is what we are going to show you. Fine, DSA and cell-mediated rejection. So if you have a sensitized patient, what do you think? He got DSA, donor-specific antibodies. Do you think he will get cell-mediated rejection or antibody-mediated rejection? You think straight away, you will get antibody-mediated rejection, which makes sense. But immunology does not make sense. You'll be surprised that the commonest rejection in highly sensitized patients who got DSA is cell-mediated rejection. It's not uncommon to develop DSA post-transplantation, 25 to 30. You can find millions of numbers and figures, but all around this range, 1/4 to 1/3 develop post-transplant donor-specific antibodies. Of course, associated with clinical and subclinical T-cell mediated rejection. This is actually the study shown by Shirkuri, published in Kidney International 2019. Demonstrated clearly that the combination of T-cell mediated rejection plus DSA led to almost 3-fold increase in graft loss compared DSA alone or T-cell mediated rejection alone. Also, the T-cell mediated rejection is quite worse, associated with higher grade compared to no DSA. So bad T-cell mediated rejection when it happens with DSA. What about the antibody mediated rejection? In this study, it's much less compared to T-cell mediated rejection. When it happened in combination with T-cell mediated rejection. So if you see antibody mediated rejection, make sure that you will get as well antibody mediated rejection. What's the clinical implication here? I'm sure all the transplant clinicians, when you see a patient just before the weekend. The weekend in UK is Saturday, Sunday. In Egypt and in Middle East could be different. Of course, you can't do biopsy because biopsy needs to be processed straight away. So we wait after the weekend. But will you treat this patient? Of course, you will start treatment. What treatment you will give? Methylpred. You shouldn't go and hit the fly with a cannonball. You shouldn't go with IgG and plasmapheresis because this patient is highly sensitized. Or IVIG, which is more expensive. You give methylpred. You'll be surprised. Many patients, when they come to biopsy, you find creatinine is improving because the commonest rejection in highly sensitized is T-cell mediated. But don't forget, if they didn't respond to methylpred, could be steroid resistant T-cell mediated or could be antibody mediated rejection. And remember, if it's antibody, usually associated with T-cell mediated, which is bad antibody mediated rejection. And the treatment, we're not discussing the treatment because plasma exchange and IVIG, you would give rituximab if you have it, many other treatments. So T-cell mediated rejection is common in highly sensitized. Let us see what Shirkuri found. Here, on the left-hand side, this is a compliant adherent patient. So the outcome of DSA with T-cell mediated rejection is worse compared to DSA and cell-mediated rejection. Here, if the patient is non-compliant, the outcome is even worse. And kidney loss is inevitable. Fine, DSA and antibody-mediated rejection. If you look at the slide, again, it's bad. Isn't it good? A lot of people muttering about, waffling about complement fixing versus non-complement fixing. They think that the non-complement fixing DSA are benign and not causing any damage. And what is really important is the complement fixing one. Let us see. Surprisingly, both are associated with graft loss, but just to warn you, different mechanism and different time scale and different duration. Complement fixing means it binds to C1q. Just to remind you, C1q is the first step in complement activation, and we have an assay for that. If we see, the assay is positive for C1q, means complement is activated. But this is not the full story. You will get, I will surprise you later on. Complement fixing, how they damage the graft. They damage the graft quickly, acutely, always hot kidney, and associated with increased chance of graft loss. Complement fixing, usually class 1, anti-class 1 HLA. Just to remind you, anti-class 1, anti-HLA A, B, and C. But I'll put the C between brackets because C is a weird HLA antigen. But mainly A and B and C, class 1. And the mechanism of damaging is complement-dependent cytotoxicity, where complement fixed, creating MAC, and this is what causing damage and vascular thrombosis and tubular damage. Also, complement fixing is not only acute, the damage as well, the kidney on the long term can cause chronic antibody-mediated rejection. Again, C1q still positive, so through the complement. So the common fixing, the usually anti-class 1, produces acute and chronic damage. Graft loss is high with this group of patients. I'm not giving tutorial for the sake of nothing, because the cases actually will mirror image all these criteria I'm talking about. And this is how I learned about this. Or another way, still I'm learning how to learn about this. What about the complement non-fixing? They are not benign. Usually anti-class 2. Anti-class 2, class 2, which HLA, DR, DP, and DQ. But the mechanism of causing damage to the kidney is different. They don't give a hot kidney, they don't give acute damage. They do sometimes, but we're talking about commonly they present as a chronic indolent damage to the kidney. How? Of course, not through complement. Don't forget that DSA themselves can stimulate natural killer cells, macrophages, neutrophils, and they have direct stimulation as well, which can cause tissue injury, endothelial proliferation. So it gives chronic changes. And this might explain the C4d negative antibody-mediated rejection. C4d is a complement component. It's not activated because the antibodies don't activate complement. But you mentioned that they can mainly chronic damage. Yes, they do as well acute, but mainly chronic damage. Fine. In the story about C1q, the first step of complement activation, there's some evidence as well that C3d and C4d binding DSA correlates better, are more predictors of graft loss compared to C1q. Why? Simply, C3d and C4d are downstream of the complement. We could have initial activation of the complement, but is aborted, like many other mechanisms in our body, inflammatory process being aborted in the middle. But again, this is a research based, but not implemented yet. On this slide is to summarize the mechanism of complement fixing versus complement non-fixing or non-complement fixing. On the left-hand side, the complement, exactly activating the complement cascade, ends with membrane attack complex, which causes cell damage. On the other hand, this is a chronic indolent, long-term, takes longer time, chronic damage of the kidney. And don't forget, this is mainly class 1, and this is mainly class 2. Remember the word mainly, not exclusively. Fine. I'm going to take you to another sidetrack, OSA IgG subclasses. There are 4 subclasses for IgG. By the way, we're not interested in IgM. because IgM mostly autoantibodies. We're talking about IgG, which are alloantibodies. IgG 1, 2, 3, 4. These 4 subclasses are different in their binding capacity to complement. The most abundant IgG is IgG1, but the most immunological and immunologically relevant IgG is IgG3. Why immunologically relevant? Because its binding capacity to complement is very high. Subsequently, binds to C1q and activate complement cascade. What about IgG2 and 4? They are non-complement fixing. IgG2 could be a weaker complement activator, but IgG4 definitely is not fixing complement. Are they benign? Of course not, they are not. But they have different mechanisms of damage. If you remember, when we mentioned class 1 and class 2, yes. So IgG1 and IgG3 most likely against class 1, and IgG2 and 4 mostly against class 2. I'm going to repeat this because of the clinical cases I'm going to present. And actually, IgG4 is a biomarker of mature alloresponse associated with advanced stage of kidney damage. So when the kidney is finished, you find IgG4, in the tissue, in the kidney tissue. This is actually the conclusion of what I said. IgG3 DSA associated with shorter time to rejection. Complement-dependent cytotoxicity, fixed complement, damage the kidney, increase microvascular injury, subsequent thrombosis. IgG4 is a later graft injury, takes longer time to damage the kidney. It could be associated with the transplant glomerulopathy and interstitial fibrosis tubular atrophy. So it's not benign in spite of being non-complement fixing. So whether complement fixing or non-complement fixing, both are damaging. The conclusion is the complement fixing one, acute damage, early in the post-transplant period. The non-complement fixing later and cause TG, transplant glomerulopathy, interstitial fibrosis, tubular atrophy. So evidence of chronic damage. IgG 1 and 3, anti-class 1. IgG 2 and 4, class 2. What about de novo DSA? Shall we put the kidney in and let the patient go home and we'll check his kidney function when he comes to the clinic? Shall we look at de novo DSA or no point? Actually, it's quite common. Again, 1/4 to 1/3 of previously non-sensitized patients, usually in the first year, develop de novo DSA. They were not sensitized before, but after the transplant, in spite of immune suppression, they develop de novo DSA. But the de novo DSA has special character, usually anti-class 2. And they found actually, and I couldn't understand why, mostly HLA-DQ. risk factors of de novo DSA: high HLA mismatches, especially the DQ, or inadequate immunosuppression, or non-compliance. Graft inflammation, this is important. Viral infection like CMV. Patient has cellular rejection, or ischemia reperfusion injury. And this is usually in cadaveric deceased donor transplantation. De novo DSA can activate complement pathway and can cause acute rejection. Even in the absence of complement activation, can cause chronic damage through antibody-dependent cellular cytotoxicity through natural killer cells, macrophages, neutrophils, or the Fc segment of the antibody itself cause cellular proliferation and endothelial proliferation, and subsequently chronic damage to the kidney. Fine. There's another study by Orbit and colleagues published in 2017. And this study demonstrated clearly that de novo DSA was associated with worse prognosis compared to pre-existing DSA. If you look at the figures, it's quite worrying here, because for pre-existing DSA, 34% graft loss compared to 63% in de novo DSA. Why? I'm going to ask you this question. Why do you think that de novo DSA are worse?
Should we be specific about the specific DSA, be it DRA?
No. Yeah, a good try. Because the pre-existing DSA, if the pre-existing DSA, we know about them. We give strong immunosuppression, aggressive induction, IgG induction, compound induction. We monitor them. We know that highly sensitized. But the de novo DSA in non-sensitized patient appears out of the wood, unexpected, unpredicted. And this is why the prognosis is a lot worse, because of they are unexpected. Also, you might be right in this bed, more due to class 2. However, many of them are due to class 1. On the long term, so you can see here, there's a lot of overlap. Nothing called absolute. There's an area of uncertainty when you deal with transplant immunology, nothing called black and white. All are gray. Actually, de novo DSA as well associated with lower eGFR and increased incidence of proteinuria compared to the pre-existing DSA. And this is evidence of chronic damage. So, in our practice, we monitor all these patients 3 monthly interval when they come to the clinic and to try to pick up the novo DSA. Look, we try, we do it, but we don't always succeed, because 3 monthly interval, what happens if after the clinic, next week after the clinic, develop DSA? I won't see him except in 3 months' time. Anyway, you should be aware of that. And for highly sensitized, of course, we'll have more attention to them. but those non-sensitized, sometimes they slip through the net. Let us see the figures and numbers for orbit. You can see here, this is incidence of acute rejection. The green one is the pre-existing DSA. Look at the graft survival, which is more interesting here. Is lower for the de novo DSA. Fine. In summary, and this table actually from Orbit as well, which is, a very good table, but I would like to highlight a few important things when you look at this table. Transplantation against class 2 donor-specific antibodies is permissible. And this is true because no kidney will live forever. Instead of this patient, hanging on dialysis for quite a long time, you can give them 4, 5, 6 years of good quality of life with a kidney transplant. It's going to reject, it's going to fail, yes, but it takes longer time to fail. Better than having all these patients on dialysis forever because they are highly sensitized. One might ask, why not to desensitize them? Actually, in spite of class 2 being permissible, you can't remove them because it, increased pleomorphism. They are highly pleomorphic. They will come back. This is in contrast to class 1. You can easily desensitize them, but again, graft rejection is associated with increased loss. In our center, we attempted once to desensitize class 1. Unfortunately, I put the kidney in. I'm the one who took the kidney out 2 days later of severe antibody-mediated rejection. Or can I say hyperacute rejection. But the kidney did work for 1 day, and then urine output tailed off. And instead of doing biopsy, we put the patient on plasma exchange straight away on IgG, but we couldn't save it. So we can play with class 2 antibodies, highly sensitized, especially class 2, but without removing them because you can't remove them. It's difficult to remove them. But this is not the only answer, and I will come to this later. DSA and C4d deposits. C4d is a degradation product of the classic complement pathway. Why C4d? Why why not C1d, C3d? Actually, C4d, this part of the complement, adheres nicely to the basement membrane. Difficult to remove during fixation with the slide. And this contributes to, they call it the footprints, fingerprints of rejection. If I'm talking about endothelium, I have to be talking about peritubular capillaries because they are quite abundant. Again, how would you do it? Actually, in Sheffield, we do immunofluorescence with immunohistochemistry. And I will tell you why. Immunofluorescence are more sensitive than immunohistochemistry. Actually, immunofluorescence is one step ahead. are immunohistochemistry. If it is borderline in immunohistochemistry, it is confirmative, it is sure, it's definite in immunofluorescence. So one question, why not to stick to immunofluorescence and forget about immunohistochemistry? If you think immunohistochemistry is not that sensitive enough to be used. No, but the problem with immunofluorescence, it stains the normal glomerulus, gives positive control. Is it important? Of course it's important, because the glomerular tuft, in addition to the cells, vessels. It could be the only sign on the only place of antibody-mediated rejection. Also, in chronic antibody-mediated rejection, the glomerular line may be the only part stained with C4d. What about C4d positive MR? Of course, associated with acute event, acute clinical presentation, hot kidney, happens earlier and more common. What about the negative one? Is it associated with good prognosis? No. Why? Because it could be complement non-fixing. Post C4d positive and negative are associated with worse prognosis. As I mentioned earlier on, whenever you have antibodies, whatever the type, is associated with increased incidence of graft loss. And the C4d negative, it could be due to a late event, and usually slightly later compared to C4d positive kidney damage. The C4d usually subclinical or could be chronic in nature. Why are you talking about this now? Because it relates closely to what I mentioned before, complement fixing, anti-class 2. But remember, nothing is absolute. There's always overlap. This is a fantasy slide, false positive C4d. Of course, what's really important is adaptation in APO incompatible transplant. We see it in APO incompatible transplant, we ignore it. Provided that kidney function is stable, no evidence of proteinuria, no evidence of tissue damage. It happens with vascular diseases, lupus nephritis, immune complex disease. But in transplant world, adaptation with APO compatible, it might happen with HLA compatible as well as a form of adaptation being reported. Fine. Third-party DSA, non-donor specific antibodies. Are they benign? If you remember the last lecture, when we mentioned the public epitopes. Yes, Craig's. And this is why we get a third-party DSA. Because the shared epitopes. You might get antibody against HLA which does not exist. Because this HLA share the epitopes of other existing HLA antigens. In the past, we used to ignore them, dismiss them, no risk. You know, oh, no, they are non-DSA. We call it third-party DSA. But Menhiro and his colleague in 2017 demonstrated clearly that non-DSA are associated with worse graft outcome if not receiving strong induction. Again, Sobrova and his colleague in 2018 confirmed the same. So it's not a joke, third-party non-DSA. And this is actually Melhir and his colleague, and you can tell clearly those who receive ET induction, the outcome is much better compared to those who didn't receive ATG induction. By the way, we use ATG, the treatment of antibody-mediated rejection in Sheffield. Memory cells. And what's the relation between memory cells and DSA? Actually, the memory cells they are the one who are behind all this. Why did they call it double sword? Because it's infection, it saves life. When I get a primary infection, the mounting immune response is quite small, but when you get the same bacteria or bugs or virus, later on, it mounts massive immune response. Less duration, less time, and aggressive reaction against the infection. So it helps, saves life. But in transplantation, it's not. This is why it's called double sword. You can see memory cells stays. And what you need, second graft, same antigens to mount a massive immune response. But let me just give you a brief idea, because there's, paradox between what's called the lifespan of memory cells and the memory, the T cell memory itself. We know that there are memory T and memory B cells. We don't know much about memory B cells. It's quite difficult to understand. There's not much work done on memory B cells. Most of the work done on memory T cells. The problem of memory T cells in transplantation is low activation threshold. If you go back to the basic immunology, we need co-stimulation molecules to initiate the T cell reaction and damage to the cell, to the kidney. But memory cell does not need that. It's very active, ready to go. Lives longer compared to the naive T cell. Is up to 160 days. Naive T cell, maximum 30 days. What's a paradox? Because this is important. The cells, memory cell will die after 160 days, but the T cell memory remains longer, up to years and years and years. Through mechanisms or multiple mechanisms beyond the scope of this lecture. Also, the problem of memory cells, T cells, is resistant to immune suppression. Need low-level antigen stimulation to mount a massive immune response. And this explains the severe rejection in the absence or even low-level DSA on retransplantation. And this is why we consider any retransplant is highly sensitized, even with zero DSA. because the memory cells are still there. Once you put the second kidney in, the memory cells get activated quickly and mount massive immune response. So the idea of this slide is retransplantation in the absence or low-level DSA. Is a red herring. Retransplant is highly sensitized until proved otherwise. This slide is again just to recap on transplant glomerulopathy. It's a chronic damage, usually the presence of anti-HLA. What's more important here, and this is actually related to our cases, is the prognosis is not entirely dependent on the presence of TG, transplant glomerulopathy, but the presence of IFTA, interstitial fibrosis and tubular atrophy. Actually, tubular atrophy and interstitial fibrosis are more important and more predictor of graft failure compared to sclerosis damage glomeruli. For me, as a transplant clinician, I wouldn't actually will do, not only the light microscopy, but also electron microscopy. But what's really important to see the double contour. This makes the diagnosis clear. Fine, we're moving now to the debatable cases. Transplanting against positive crossmatch. This is our experience. Remember, it's not one-man show. It's not Ahmed Halawa. It's a teamwork. Surgeon, nephrologist, immunology lab, and transplant coordinator. We discuss together how we are going to take it further and what we are going to do. I would like to remind you that we dropped the PRA. PRA does not exist and should be removed and should be abandoned. Does not reflect the real life. Does not reflect sensitization. Is totally inaccurate. Is not reproducible. Is one of the methods we still have. Is one of the old traditions we should get rid of. And being replaced by CRF or CPRA. PRA, looking at 25, 50 patients, maximum 100, but the CPRA or CRF, calculated reaction frequency, this is what we call it in UK, is 10,000 potential donors. Facts, crossmatch, we dropped the CDC, which is really, really bad. We dropped it 10, 15 years ago. Now we have increased number of patients, highly sensitized patients coming through the door needs transplant. And we wish that we have the CDC with the facts crossmatch. Because if you have facts crossmatch positive, because this is very sensitive, and CDC negative, this means intermediate risk. You can go ahead, but you need to look deeper into the HLA mismatch profile. Is it class 1 or class 2? The DSA profile, is it class 1 or class 2 or mixture of both? Which one is higher? MFI. The patient I'm going to present all received aggressive induction, ATG. One patient received alumtuzumab. No antibody removal, no plasma exchange, nothing, because one of them was living, but we'll discuss it separately, and 3 were cadaveric, deceased donor transplant, where there's no time to do plasma exchange. You do it once. Actually, the first one, we did plasma exchange, and then we checked the antibody level, but I proceeded with the transplant because I can't wait, the kidney will get damaged. One session of plasma exchange did not touch DCA level. The 3 who received deceased donor cadaveric transplant were sensitized against HLA-DP. Again, if you remember part 1, DP is different. We use lymphocyte for crossmatch. Is it right? As a surrogate marker of the kidney. But lymphocyte is not the kidney. The kidney behaves differently. DP expressed very well, and the rest of anti-class 2 or class 2 HLA, expressed very well on the surface of lymphocyte, but not well on the kidney. So you could have positive cross-match, but in reality, the kidney is missing the DP, not well expressed. So you have the antibody, but you don't have the antigen. So you won't get the acute event. Anyway, let's move. Here's one. "68 years old male, end-stage renal disease secondary to interstitial nephritis, received his first kidney transplantation February 1984 from his brother, rejected his graft and had graft nephrectomy on July 84. He's on warfarin because of AF and has a pacemaker. In 1987, received the second deceased donor transplant, failed 12 years later, secondary to chronic antibody-mediated rejection, back on dialysis, August 2009. Received third transplant in March 2015, DBD kidney 111 mismatch. It was an elderly donor. Patients highly sensitized with calculated reaction frequency, 100%. So we got everything. Positive cross-match, mainly due to DP3 on Luminex single antigen beads. High mean fluorescence intensity, 22,000. Positive T and B cell on flow cytometry. What's really important when you come to transplant highly sensitized who is positive on crossmatch? You need to know how positive is positive. Is it strongly positive or weakly positive? You need figures and numbers to tell you whether it's strongly positive or weak positive. And this is where the cutoff plays here. Relative mean fluorescence is 2.52 and 4.1, and the cutoff is 1.48 and 1.88. If you notice here, it's slightly, or I would say there's a borderline or weakly positive. This reassured me that we can go ahead and transplant. Induction with ATG, of course, delayed graft function, biopsy 7 days later, no rejection, improved, kidney opened up, south-pass urine, went home on day 16. Outpatient clinic, He had deterioration of kidney function 2 years later because he had to go through a cardiac operation, aortic valve replacement. Anyway, latest creatinine, 212 micromole per liter, which is 2.2 something milligram per deciliter. TAC level, kept TAC level, but on the higher side. He developed proteinuria. Biopsy showed TIG, transplant glomerulopathy, but no tubular atrophy, no significant interstitial fibrosis. This slide demonstrates his kidney function. You can see at the end is around 26, 27 for quite a long time. Remember, I was transplanted 2015, kidney function now 2021, but this data till 2020. 5 years, despite of TG, despite of transplanted, again is positive T and B cell crossmatch because of DP. And this is a proteinuria. And treated with AC inhibitor, we kept it down. I've seen this patient a few days back, kidney functioning, was complaining from something else. Don't forget he had a cardiac operation. Fine, here's antibody level. This is where he was transplanted. Antibody level went down after transplant. We stopped in 2018, 3 years from the transplant, to measure antibody level. Because you got TG already, you got coronary kidney damage. But still functioning 5 years down the line. Second case, a 58 years old male patient, end-stage renal disease secondary to membranous nephropathy, received first DBD kidney. DBD means donation after brain death. In March 98, subsequent chronic allograft nephropathy, back on dialysis. In January 2017, received a DBD kidney, 1-1-0 mismatch. Again, an elderly kidney, I think 62 years old donor. Patient was highly sensitized again, CRF 100%. Again, BP3. Pneumonex single antigen bead identified DP3 was MFI 9763, positive again T and B cell. Relative mean fluorescence, which is how strong the positivity, how strong the negativity. Again, borderline, weak, but positive, definitely positive on B cells and T cells. IgG induction, followed by triple maintenance. Develop DGF. DGF is very usual, very common in highly sensitized patients. Allograft biopsy on day 7 showed no rejection. Urine output picked up, improved. latest creatinine 229 micromole per liter, GFR 26. Top level of tacrolimus is 7.1. This is his eGFR. I brought this slide to demonstrate something. And this is actually the real, creatinine. In highly sensitized patient, it will be like a yo-yo, jumping up and down. If I have very low thresholds of biopsying this patient, he could have 9 biopsies. But all agreed not to do anything because the biopsy won't change the treatment unless he has an acute event. We admitted him twice for biopsy. Next day before the biopsy, we check creatinine improved. Anyway, so we kept him as he is, with maintaining GFR. Now he is in his 4th year. But what's going to happen to this kidney? Eventually it will fail. We know it's anti-class 2 antibodies. We know it's a chronic kidney damage. It takes years to damage the kidney, but at least we get him a good quality of life for a few years. Also, we save some money. And I will tell you why. Urine. Proteinuria, but by the time we thought, biopsying him, proteinuria improved. But our cutoff usually for proteinuria is 200. Below 200, we know it's bit, we keep watching it. MFI, this is where he was transplanted. MFI went down, closer the GP3 went down. Many explanations of low antibody level, DSA level after transplantation. It could be absorbed on the kidney. And most likely this is the case. The kidney acts as a sponge. And this is why you will get a kidney damage at some stage. This kidney won't survive forever. But at least now he's in his 4th year. Case 3. Is a 53 years old male patient, second to unknown etiology. He is an Asian. Received his first kidney transplant in February 1984 from his brother. Ended up by graft nephrectomy same year. Second transplant in August 2019, 1-1-1 mismatch. Remember, this patient we discussed early on because his cross-match was a bit challenging, and I'm going to highlight it in the next few slides. Patient was highly sensitized, was calculated reaction frequency 100%, CPR 100%. In PRA terms, would be 100% as well. But here, the positive cross-match is due to DP13 and DP19. But T cell negative, but B cell definitely positive. Again, relative mean fluorescence 3.3 for B cell, cutoff 1.48. and 1.88 for B cells. So again, it's a weak positive or borderline positive or slightly positive, but not strongly positive. By the way, there's no definition how weak is weak and how strong is strong. But being from ethnic minority, the chances of getting a kidney, especially in UK, where most of the population are white, so the chance is quite less. So we decided just to give him the first coming kidney. We know that he's highly sensitized. We counseled him, and we did tell him this kidney may not last at all, may last for a few months, few years. We don't know. You know, are you happy to take the chance? He actually was quite happy to take the chance. To be honest, you know, if you offer any dialysis patient a kidney, he will accept it. Induction, the induction is differently is alemtuzumab. Because, you know, I thought IgG is quite, you know, labor intensive. You have to put a central line and give it over 3-4 days. Alemtuzumab is just one injection, 30 milligram on day 0, day 1, subcut. Immediate function.
Hello.
But he developed acute antibody-mediated rejection on day 10. Received plasma exchange and IVIG. Over the next few months, has improved kidney function around 27, 28, 30. TAC level 8.6, no proteinuria. And this is actually the same what Crossmatch I presented in part 1, because this will explain the complexity of this patient. If you remember, we discussed he's, you know, Asian, so the rare HLA antigen, we defaulted this rare HLA antigen to one of the common antigen. And the actual cross-match is tissue type, you know, is 222 mismatch. Actual mismatch is 222. If you look at here, it's all positive for B cell, negative for T cell. But there's something, again, worrying here, because this patient had also donor-specific antibodies, but again, it's HLA-A2. And this is why we decided to go ahead, because HLA-A2 is a common HLA antigen in the white population. More than 50% of population are HLA-A2 positive. But lucky enough, it didn't cause T cell cross-match positive. And this is why I thought, let's go ahead. So it must be below the threshold. Again, this is the biopsy for acute antibody-mediated rejection, and kept creatinine, you know, around 30, G4 around 30. Now we are in the second year after transplantation. And this is a proteinuria. And this is the DSA, DP13 and DP19. If the kidney function is quite stable and no evidence of proteinuria, I'm not planning to biopsy him, because actually he will do nothing. He's highly sensitized, CRF 100%. We know that is going to happen. The only thing we can do is to pick up acute rejection, which can be treated, but chronic rejection won't be treatable. And he got antibody-mediated rejection here, which was treated. Fine. The last case, I would like just to highlight something, non-HLA antibodies, how they present. Actually, they're associated with increased risk of antibody-mediated rejection, reduced graft survival. There are millions of non-HLA antibodies. The typical feature on crossmatch is positive flow cytometric crossmatch in absence of DSA on single antigen beads. Means non-HLA antibodies. Case 4, a 57 years old lady on a transplant waiting list for 11 years. Her primary disease is other polycystic kidney. Family friend came forward for donation. The mismatch is 0-1-0. Fax crossmatch is positive for both B and T cells. Auto crossmatch is negative. There is no DSA detected. But fax positive, so it must be non-HLA. What's the explanation of this crossmatch? Yes, is non-HLA antibodies. Would you go ahead and transplant her? We did at that time. Is it right or wrong? This was in 2016-17. We haven't had a paired exchange scheme started at that time. In reality, it happens in the last few years. We'll put her on the paired exchange scheme, because this is what you will get if you put a direct transplant. We got, yeah, 14. So we got 4 years out of this kidney. And we have seen her kidney function drifting. Not only that, proteinuria, but we know it is due to non-HLA antibodies. But over years and years and years, she had induction IgG. Also, this lady had a lot of comorbidities. She wouldn't tolerate aggressive immunosuppression. When we biopsied her, the biopsy again is not informative. Possible endotheliolitis. It's not a typical picture of chronic antibody-mediated rejection, no antibody, acute antibody-mediated rejection, or cell-mediated, something weird, something in between, does not fulfill the criteria of any forms of rejection. But the slide look abnormal. Negative for C4d, no DSA, nothing to treat. For the sake of publications, we looked at which non-HLA antibodies. We found that human neutrophil antibodies is the one which causing her graft damage, chronic graft damage. Again, if it's 2021, wouldn't go and do direct transplantation, but the paired exchange scheme. But at least we got 4 years out of this kidney for this highly comorbid patient. This patient died on dialysis after kidney failure. I think it was 2 or 3 months after landed on dialysis. This will tell you how fragile she was. Fine. Why on earth do you transplant these people? And we know that the kidney is going to fail. We mentioned the quality of life and survival. Look at this figure. These are UK figures. And you realize how much money will be saved each year after transplantation. Dialysis is not cheap. Transplantation is a lot cheaper, in addition to the improved quality of life. We'll give them 5-6 years out of these kidneys. We'll be fine. The debate is how to monitor these highly sensitized patients. DSA frequently, graft function, proteinuria, frequent biopsies. No answer. We go by graft function and proteinuria. We have nearly 4,000 patients on our follow-up. Many of them are highly sensitized. So logistically, graft function, proteinuria, and DSA in the first year, biopsy when indicated. So again, all are associated with worse prognosis, but some of them are bad, just bad. Still, you can go ahead and transplant and give them a reasonable quality of life for a few years, and you save money as well. Aggressive induction. Class 2 is difficult to remove in the desensitization program, but you can give damage after a few years, and this is what you need. Will you do it for every patient? Of course not. Long waiter, instead of dying on dialysis, you give them the first offer, provided that is reasonable, no suitable live donors, we give them a deceased donor kidney, borderline high RMF. We made use of the low expression of HLA-DP and also the rest of class 2, DQ and DR as well. And we wish good luck. Different monitoring practice, as I mentioned earlier on, DCA, biopsies, or would you just monitor the kidney function? These cases submitted for publications in the Journal of Nephrology. Also, I would like to highlight, I'm talking about high DSA, but this is an important publication of my team as well. When you have lower level antibody, DSA, and negative flow cytometry, this meta-analysis is addressing the outcome after 1 year. So short-term outcome is quite good. Because the definition of low-level DSA is variable. It depends on which DSA, class 1, class 2, and which one of class 1 is HLA A or B or C, and then class 2 the same as well. I want you just to read it. The presence of DSA, what I'm addressing here, presence of DSA is not a contraindication for transplantation, but it's an indication for aggressive induction and frequent monitoring. references, and thank you.
Thank you very much, Professor Halawa, for this very, very elegant presentation. I really enjoyed it. And I, first of all, I would like to thank you and congratulate you. To thank you for this, presentation. Actually, when you hear or you listen to a transplant immunology from a physician or a surgeon has a different taste. I think then it's better than or easier than to have it from an immunologist. It's much easier and much palatable. Actually, I enjoyed it. And I would like to congratulate you for the your achievements and you and your group in transplanting such difficult and challenging cases. Congratulations. Let me start by a comment. Yani, what your recommendation regarding as you said in your last slides, is post-transplant screening or monitoring? I think there is a debate about to routinely monitor transplant patients with DSA post-transplant. There are some publications. I think one of them is one recent in the Kidney International in 2019 from Wisconsin, that they concluded that in absence of biopsy-proven rejection and acute inflammation, DSA are not associated with the risk of graft failure. However, I don't agree with this policy. I think we should have increased our monitoring for our patients either by surveillance biopsy or DSA, especially for those of high risk, whether poor matching or preformed antibodies, or on adoption of minimization protocols. I think we cannot adopt minimization protocols without post-transplant surveillance for DSA and protocol biopsies. So, would you recommend a certain algorithm for monitoring in the first year and then later on for those patients? This is my first question. And the second is, you addressed a very nice 3 points: the memory cell, the double sword. This is we can say the bold and beautiful memory cell. Of course, it's the bold in transplantation. And the false positive C4d, we cannot always rely or look for C4d as a gold standard for diagnosing antibody-mediated rejection. As you said, we could have false C4d and ABO incompatible in some immunologic disease like lupus and so on. Can I have your comments about my...
Actually, regarding monitoring, most of the rejection will happen in the first year. And most of tailoring immunosuppression as well, this is what you need during the first year. So highly sensitized, completely different ballgame. It depends what they are sensitized to. But generally speaking, if you have highly sensitized and the number of highly sensitized patients will increase on your waiting list, if you want it or if you don't want it, they will increase. So proteinuria, graft function, biopsy, if you can, would be good, and DSA. DSA, again, DSA monitoring is quite disappointing because in spite of having TG in the first one, there's evidence of graft damage. DSA was very low because, the kidney acts as a sponge. This is my perception. And I sucked in all DSA. But having DSA on the kidney, they must be doing some damage because this is why you get TG. Okay. The last case again, you got DSA, and the DSA produced antibody-mediated rejection. So if you can tell here that we have 3 different outcomes, same DP, one didn't have any rejection, one have transplant glomerulopathy, evidence of chronic damage, another one acute damage. And this is why I brought these 3 cases, because in spite of the same antibody, 3 different outcomes. And this is actually described the whole picture I mentioned on, acute rejection, chronic damage. So back to your question, monitoring at least in the first year. When they are stable, they still have to be monitored because they will have chronic damage later on. But the chronic damage, chronic antibody-mediated rejection, what a treatment? There's no treatment. A lot of articles, papers, to give rituximab. Yes, we did it in 2 patients. After 1 dose of rituximab, proteinuria significantly decreased. But 6 months later, the kidney failed. So this is a disease with no treatment. What we aim at is to keep this kidney functioning as long as we can, but we have to look at the patient as well. I will be focusing on the kidney and saving the kidney and killing the patient with CVD and all sorts of infection because of aggressive immunosuppression. You can see here, these patients, the first one had 3 transplants, so he had gallons of immunosuppression. And this is why we were reluctant to interfere more and give him aggressive treatment, especially we don't know whether it's going to work or not. So monitoring, it depends on your capacity. One size does not fit all. If you can monitor with DSA, but be aware that DSA level can go down in spite of ongoing damage. Biopsy, but biopsy, you have to have light microscopy, electron microscopy as well. Plus, the easiest way is graft function and proteinuria, but this usually a late sign when kidney get damaged. But in reality, as I mentioned earlier on, we see this patient every 3 months in the first year. We monitor DSA every 3 months. What happens if the next day he developed DSA? You wouldn't discover it except 3 months later. The only way is to bring the patient every day for the first year, 365 days, and you do blood and DSA every day. Well, it will be anemic and hemoglobin of 4 at the end of the first year. So practicality is all about the practicality.
Okay.
Did I make it difficult?
No. Okay, I leave the comments for Professor Hani and Professor Ashraf.
Thank you very much. Very elegant presentation for a very tough subject. Could you, in your case number 3, this patient you gave alemtuzumab in spite of having the worry of memory cells after his second transplant. Why you choose the campus, although we know that campus sometimes causes rejection because of the memory cells?
Okay, we are talking about, Professor Hani, thank you much about the 3C study, the short-term 6 months and the long-term 5 months. Actually, logistically, Campat is easy to give, easy to monitor. Actually, ATG, when you give ATG, you have to put a central line in the middle of the night because you're going to give ATG induction, and you monitor every day before the second dose. We don't do actually the C4d or C4d, I forgot it, with the OPT3, but what we do is lymphocyte count and platelet count. So Campus is one injection. Logistically, we give it in the in theater, subcut, and finish the game. Regarding the rebound of antibody-mediated rejection, is not shown. He didn't have rebound.
In this case, it didn't, but in the literature, they are reporting some cases of resistant rejection after Campus.
Yeah, but on the 5 years long term, actually Campus was favorable. I think this was a worry in the 6 months in the short trial. Somebody correct me if I'm wrong. I'm talking about a 3C study. The short term, which is 6 months, yes, there is a worry of rebound antibody-mediated rejection after 6 months, because this is the duration Campus works. But I think the 5 years follow-up didn't show this. So we have forgotten about it completely because we thought it does not exist. It is just was an observation which was not confirmed.
Okay. Thank you.
Professor Ashraf, you have a comment?
Yes, thank you, Professor Ahmed, for your effort to simplify this hard topic again. But frankly speaking, it is more complicated. I will be so reluctant to proceed for transplanting any case of these 4 cases. But of course, you have a better tools than ours, and you have a better luck as well. I will focus on one point: HLA-DP donor-specific antibodies. I understood from your presentation that you consider these HLA-DP donor-specific antibodies are as deleterious as anti-HLA ABDR-BQ DSA. Even in the presence of high mean fluorescence intensity, you proceeded to transplantation for such cases with a plan for potent induction and triple immunosuppressive regimen. What is the risk of infection in such a situation? I am so much disappointed because the outcome of these transplanted cases are not so good. We have a low GFR and the survival is not so good. But your slide signifying that the cost and the waiting list and the, of course, the discussion with the patients will make such a decision for proceeding for transplantation of such cases more easier for you. And thank you again. But it is, as you said, it is an ocean, and we are trying to swim for the sake of our patients. Thank you again.
Fine. Okay. There is a risk, but it's called calculated risk based on evidence. The DP expression on the kidney is not that as good as the lymphocyte. So you might get positive cross-match, but in reality, you won't get antibody-mediated rejection, acute or hyperacute rejection, because the DP may not exist, may not presented well on the kidney. And this is the chance, this is a small window of opportunity you sneak in order to, one of them was waiting on the waiting list for 13 years. Will you keep him on dialysis for another, God only knows, till he dies? Or you give him a chance that it could be 50% chance of the kidney to work. And the first case you pointed, surviving for 5 years. We're looking at dialysis-free patients rather than excellent kidney function. It will never be excellent. And we know from the beginning, this kidney was going to fail. Either if he escaped the acute antibody-mediated rejection and they dead, they will get the chronic one. Not only that, only one patient got antibody-mediated rejection after this 10 days, was the third patient treated. still dialysis free, and still have reasonable quality of life. I would like to remind you that the DP patients all received deceased donor kidney. I will think a million times before offering them a living kidney.
I think this is the point, Professor Ahmed, that we are treating such patients like patients who received kidneys from marginal donors.
Absolutely.
It's better to have, better than to leave them on dialysis. But this is, of course, applicable in diseased donors, but we cannot apply it for living donors.
No, actually, the one who received, the marginal recipient who received a kidney from her relative, and the kidney survived for 4 years, and she's on the waiting list for 11 years.
Yeah.
And we thought if we didn't transplant her, she could be dying next year. So we'll go for another 4 years, of good quality of life. And what happens? After failure of the kidney, 6 months later, she died. She didn't tolerate dialysis.
Mm-hmm.
So,
okay.
All these cases are very unusual. This is not the standard practice.
Of course.
But as I mentioned earlier on, the one who received a kidney from a living donor and the cross-match was positive due to non-HLA antibodies. In 2021, we could have offered her a paired exchange scheme. And this is a point for you to think about it. And instead of having a highly sensitized patient and denying them a transplant, why not to arrange paired exchange scheme locally? The paired exchange scheme in UK is national, but at least you start locally. Couple 2 pairs and see which one is better than the other one. You can do it. Logistically, you can do it.
Okay, we have Professor Shaheen, Professor Mohsen Al-Qusi with us. Would you like to comment?
Thank you very much. I enjoy too much, Professor Halawa, and I am sure that if we compare the outcome of paired exchange and exchange of the donor, maybe the outcome will be better than to take such a risky patient. But I am like you. I have the same situation, in especially in Saudi Arabia, that we have some patient who had donor. I am speaking about living donor, and they don't have another choice. They cannot go for a paired exchange. They cannot, they cannot bring another donor. There are only one donor with them, and so we may face this problem. We may have this problem with us. I appreciate too much the excellent talk, which I'm always learning from you, Prof. Halawa, every time I heard you.
Yeah, it's a good, thank you, Professor. Actually, it is just, another thought, another way of looking at this highly sensitized rather than denying them kidney transplant. Yeah, of course. If I don't have the paired exchange, I would go for anti-class 2, positive cross-match with proper counseling, proper discussion with the team, and proper monitoring. Patient agreed to take the risk, and we are happy to take the risk. We'll go for it, rather than saying no.
Okay.
We're looking at patient survival, quality of life, rather than center outcome.
Okay.
If you didn't have any complications, you haven't done enough transplant. If you didn't have any rejection, if you didn't lose any kidney, you haven't done much work. And this is what we believe. We lost kidneys. And I mentioned, when we transplanted, the first positive cross-match against class 1 positive cross-match failed in front of my eyes. We couldn't do anything. but we thought we'll change the practice. Instead of class 1, let's just go for class 2.
Okay, thank you.
Dr. Kusi, do you have
Yeah,
any comment?
Yeah, thank you very much. A very interesting talk and a very hard topic, as everybody has mentioned. And I believe Professor Halawa has addressed the question that you are dealing with a completely different set of patients compared to what's been happening in Egypt. Because, I mean, all patients, they are live donors. So probably these cases would be extremely difficult to consider for this type of donation. I believe that you will be very hesitant and reluctant to risk losing any graft of all those patients. So probably this might be the difficulty or the challenge. And you correct me if I am wrong. I believe that this is the main challenge you are facing in Egypt, that you have got live donors. You don't have a deceased donors, when if you lose the graft, it will not be a huge problem. This is my comment.
Yes, as well. I mean, don't forget as well, Professor Kosi, that we are dealing with patients who can take the risks. But maybe in other parts of the world, people are not accepting any risks. If they are not accepting any risk, we can't do anything about, we can't do anything about it. We can't help them.
I'm sure that I do appreciate all what you are saying, and which is very applicable in any other parts of the world. But probably my colleagues, correct me if I'm wrong, having considering one of those patients to just carry the risk of losing a live donor graft, it's very painful, even if you put it on your mind before you consider it. I'm not sure. This is my feeling.
No.
I
totally agree.
Yeah,
I might be wrong.
Absolutely.
Totally agree. Yeah.
But does it mean that you will never lose a living donor transplant?
You will lose it, but for different reasons.
Yes.
And if you have lost it, you will not that be blamed. But if you have lost it, and you know that there is a bit of a risk, huge risk because of hospitalization.
No, what I meant here, we have to take the risk. We're taking the risk. I mean, we used to say any surgeon who didn't have any complication, he didn't do enough operations. He didn't operate properly. We have to take risks, but it's a calculated risk. And this is why I'm addressing, there is a room around it. There is room for maneuver in class 2. This is what I'm saying. So instead of no, let us think about it. Is it possible? Yeah, it is possible. Yeah, it is permissible, can be transplanted, but the long-term survival won't be great. Maybe short-term survival also won't be great. If the patient willing to take the risk, will go for it.
Probably, I mean, lessons to learn here. I mean, improving the calculated risk. If we say that not to rely mainly on the PRA, you might need to do the other forms of assessment for those patients. This is something that might need to be considered to just make your assessment near to right.
Absolutely. Number one, you can't take the risk if PRA is the main screening system, or if you don't have flow cytometry. But as a matter of fact, CDC is important to quantify the risk as well. So we have to have CDC and flow cytometry. And to be honest, some of these patients who could be CDC negative, and it's part of being highly sensitized, because we know CDC is not sensitive enough to pick up antibodies. But in the past, 10, 15 years ago, when we used to do CDC, we transplanted a lot of patients. We discovered later they are highly sensitized and their transplant is successful. So we have to have, a lot of things together in order to make our risk assessment. Also, the induction, I presented it in simple induction. Is no plasma, exchange, plasmapheresis, all sorts of things in the middle of the night. you know, for the deceased donor transplant, which you need to transplant within hours, is totally inapplicable. It did work. Graft function is not great, but the graft is functioning. Patient still alive. Quality of life is better. We saved money. We're not looking for excellent function. It will never happen. Even with full house match kidney.
Professor Halawa, you didn't perform a surveillance or protocol biopsy for such high-risk patients. And in the future, would you consider do it at 2 weeks, 1 month, 3 months, and so on, to intervene early rather than this, relying on DSA only?
No, yes, thank you very much for this important question. Fine. Graft biopsy, you do biopsy if you want to change your management. We know that this class 2, we know that it will be associated with chronic kidney damage. It takes a while to damage the kidney. We know there is no treatment. Why to do the biopsy? Biopsy could be misleading. Why? When you do plain X-ray test, when you ask a radiologist in UK, will you do just plain X-ray? Will this plain X-ray test will change your management? No, you wouldn't do it. CT scan abdomen for somebody who got perforated appendix. Will you just change your management? No, I'm going to open him up. Okay, no point of having CT scan. So any intervention should be associated with significant change of practice or offer the patient new treatment. But we know it's class 2, and this is why I explained all this antibody non-fixing and all sorts of things before. We know that this is going to happen, and this is why we didn't bother much about the biopsy, only in the initial period to make sure there's no antibody-mediated rejection. And then we know that this kidney is going to fail. It's a matter of time. We aim that this kidney will survive longer. And first one is 5 years, second one is 3 years, another one in the 4th year.
I think there is a lot of reports documented the presence of subclinical antibody-mediated rejection in the protocol biopsy, and I think to intervene early for such subclinical antibody-mediated rejection in such high-risk patients, I think it could save rather than to wait for an event biopsy, which could be late.
Yeah, I mean, save. Okay. Okay, so you did a biopsy after a year, and I like this debate. You did the biopsy after a year, protocol biopsy, and the protocol biopsy showed chronic antibody-mediated rejection for somebody who had 3 transplants. He was on immunosuppression for 25 years. And it's anti-class 2. Chronic kidney damage is going to happen. Chronic antibody-mediated rejection is going to happen. What's the treatment then?
In the presence of increasing titer of DSA as well, we can go for plasma exchange, rituximab, even with normal serum creatinine.
Oh, yes, good. Thank you very much. Well, these are not effective, not proved to be effective in chronic antibody-mediated rejection.
We are dealing with unusual scenario. These cases could not be transplanted in the routine practice, so we are not following the guidelines from the start.
Absolutely, but there actually there is no treatment up till now for chronic antibody-mediated rejection.
Can I just have a little comment? Probably, maybe the protocol biopsy is to avoid the full-blown picture of acute antibody-mediated rejection, rather than the chronic form that there is no, the treatment is doubtful to make any difference.
Yes.
So probably you might be able by the protocol biopsy to pick up some acute antibody-mediated rejection, some florid forms. You will avoid this type of rejection. And to be honest, in reality, I believe those patients, if you compare them to the others, they will subject to have many biopsies compared to the others. As far as I mean, Professor Ahmed can correct me if I'm wrong.
Yeah, absolutely right. You know, one of them, if I relied on the clinical function, you know, creatinine was like a U up and down. I could have biopsied him 9 times.
Right.
So there's no.
And what I'm saying is, yes, they end up having more than usual number of biopsies, maybe near or close to the protocol biopsy. And I believe the role of the protocol biopsy in these circumstances is just to avoid a florid form of acute antibody-mediated rejection, which might not be amenable to treatment even, or to recover from any conventional approaches that we have.
Yeah,
this might be, I believe.
No, actually, we did biopsy 2 of them at the beginning. Actually, no, the 3 of them were biopsied, because the first 2 were DGF, so were biopsied. There's no acute rejection. The third one got definitely, after initial function, creatinine went off, and we biopsied, and it was antibody-mediated rejection. But afterwards, creatinine, you know, improved, came down. But again, don't forget, these are marginal. We call them expanded criteria donor kidneys. So
Yes.
basically, they're from elderly donor. You know, I think 2 of them were hypertensive, and one of them was diagnosed to be early, you know, early diabetes. So there's marginal kidneys as well from an elderly donors into highly compromised recipients. But at the end of the day, it's debatable. You know, it's all about how would you do it, how you think. There is no right or wrong answer. It depends how you feel about it, because the evidence is not strong. But there is no evidence to support effective treatment of chronic antibody-mediated rejection. And this is the point. We wish we, you know, if we have, would be good. At least we could save a lot of kidneys. But anybody can show me evidence to support treatment of chronic antibody-mediated rejection. No. Don't forget as well, you know, they've been on immunosuppression for a long time. Plasma exchange, IVIG, and rituximab. Again, it's too much. You know, too much immunosuppression.
Okay. Any other comments or questions?
Would you consider desensitization protocol
yeah.
before transplantation in such patients receiving deceased graft with negative cross-match and positive? Yeah. Okay. Actually, the problem with desensitization is not only 1 session. You have 10 sessions or something to reduce the level of DSA. And the principle of desensitization is to render the positive cross-match
negative.
Yeah, rather than the disappearance of DSA. Don't forget the memory cells double sort. You know, there will be, after the transplant, definitely surge of DSA. So there's no time. I did a trial. Only the first patient let me get plasma exchange just few hours before the transplant. It didn't turn his hair. It didn't touch him. DSA level is still high. So we decided just to go ahead. The best way is not to expose this kidney to ischemia reperfusion and transplant it quickly as soon as possible. Otherwise, again, they will be, you know, immunologically, you know, vulnerable to the immune system because of ischemia reperfusion injury and DGF. In spite of this, 2 of them developed DGF.
You have a desensitization protocol in Sheffield, Dr. Ahmed, and what's your protocol?
Yes, thank you very much. We are completely now discount regarding desensitization. And even we stopped doing the EPO compatible. Why? Because of the paired exchange scheme.
Okay.
You know, if we have, every month we have 3 or 4 patients get transplanted based on the paired exchange scheme. Yes, we are the skills regarding desensitization. Except this is, we're talking about living transplant. But the deceased donor transplant, of course, there is no periodic exchange scheme for them. It's just, it depends on what you get.
Yeah.
So for living, if we have similar scenario in living, for them and the periodic exchange scheme, we'll get a negative cross match from a donor who are not sensitized to. This will save the patient's life, improve the graft survival, convenient, scientifically right, rather than challenging this patient and put them through the smell.
Okay.
And all this induction immunosuppression and protocol biopsies and DSA and all these things.
Okay.
How could you make difference
Yeah.
between rebound DSA after kidney transplant and de novo DSA? Can't make a difference. But the definition of de novo DSA, somebody who is not sensitized, usually male, because male the less likely to get pregnant, not blood transfused, no previous transplant, and DSA is negative. But if this one developed DSA later on after transplantation, definitely there are de novo DSA. But the pre-existing DSA, their profile beforehand, and what you need to monitor is the level up and down.
Yeah.
You spoke about plasma exchange, non-effectiveness in removal DSA. Does IVIG and rituximab have a better effect? Actually, the rituximab and IVIG are used in conjunction with plasma exchange. And this is what we do. It's not one treatment. They will get multiple treatments to desensitize them. It's not only one tool. You have to hit them hard with multiple tools. And now there is no room for desensitization because of the periodic exchange scheme. But still, we play with that in the deceased donor transplant because there is no periodic exchange scheme for the deceased donor transplant.
Okay. Any other comments or questions from the audience? Please raise your hand for those who need to answer the question. I think. Can you see the questions on the chat?
Yes. So the question is, would the decision of proceeding to transplantation differ if detected anti-HLA-GP antibodies were in a patient receiving his or her first transplant compared to another receiving his or her third transplant? No difference at all, because sensitization not necessarily because of the kidney transplant, could be because of blood transfusion, could be because of pregnancy. The second patient had only one kidney before and was enough to sensitize him. And we have seen a lot of patients who are sensitized but didn't have any transplant before because of blood transfusion, pregnancy. All these are sensitizing events. Niado, I could understand the question, but I'll read it. Also, effect of DP, but more sustained immunological stimulation with immunosuppression. There has been a gradual drop on DP, DSA over the years, despite of lower levels. If it's possible, initial damage DGF is underestimated. Yes, DGF is one of the sensitizing event, because what happens with DGF, any kidney damage, any kidney injury will expose the immune system, will expose the HLA and make the HLA exposed to the host immune system. Of course, DGF will try to avoid. This is why we need to transplant this patient as soon as possible, rather than waiting for plasma exchange another few hours to go before we transplant them. Does the significant DSA level in your lab differ according to the importance of anti-HLA antibodies? More significant HLA antibodies against the... No, it's no. Actually, it is well-known fact that class 2 are permissible. Class 2 usually not well presented on the kidney, but well presented on the lymphocyte. It's nothing specific about the measuring technique, because you measure the DSA level using single antigen bead, which is standardized.
Dr. Halawa, would you have any special practice for the cases with non-HLA antibodies? I mean, either for the preparation, for the risk stratification, or treatment post-transplantation? Is it differ from the DSA?
No, it's different. It's not different, but it's more difficult because you don't know what you're dealing with. Loads and millions of non-HLA antibodies. So basically, monitoring kidney function, proteinuria, and even if you only one case we have presented. Actually, we are 4 cases. We published 4 cases of this scenario proved to be neutrophil antibodies, and the presentation is quite similar to anti-class 2. One of them presented of acute rejection. The other 3 presented with chronic damage, like the case presented. So nothing specific. It is all about counseling. It's all about accepting to take the risk. It's all about patient assessment. If he's intolerant to dialysis, being long waiter, happy to go ahead and take the risk, and we quantify the risk. That the risk of rejection, either acute or chronic, but this kidney won't last for forever. If they are happy to go ahead, we will go ahead. And immunosuppression wise, aggressive immunosuppression. And good luck.
I think you prefer always the alemtuzumab rather than the ATG. That's right. You feel it.
We moved from ATG with the pain in the head, because ATG central line and monitoring and the dose and all sorts of things, but alemtuzumab 1 or 2 doses. Actually, we moved from 2 doses to 1 dose, subcut. That's it, and finished. No monitoring.
Yeah.
Easy.
Totally agree. We tried alemtuzumab in 62 patients in our series, and it was very easy to handle. It's only 1 dose, 30 milligram, 2 hours prior to transplantation, and the lymphocytes are vanished from 40% to 0% prior to transplantation, and they stay around 2 to 5% in the first 6 months post-transplant. And it allows us to transplant the patient steroid-free and CNI-free, even with the help of alemtuzumab. The problem that it is not available anymore in Egypt for, I think now for 10 years. This is the problem.
But I mean, alemtuzumab is a marvelous drug in terms of administration, in terms of monitoring. And I think if you think about it, it's a lot cheaper.
Yes.
Because you will give it to yourself rather than putting a central line and the injection is subcut, 1 shot, finished. But unfortunately, the availability is important. This is why I moved to alemtuzumab, because I give it myself just a few minutes before the operation in an anesthetic room, actually, and that's it, finished. But of course, we have to give the same pre-medications like AgG to the patient, but is easy, manageable. We're looking for something which could be safe,
yes,
easy, administered. Don't forget, dealing with a deceased donor transplant will be 3 o'clock in the morning. Who's interested to add to the central line and giving AgG induction?
Yeah,
no. I'd like to make life easier.
Yeah, totally agree. I want to assure all the audience that this elegant presentation will be soon on the Academy and on the YouTube. So tomorrow morning, inshallah. So thank you very much. Thank you very much,
Thank you
Professor
very much
Halawa,
for the invitation.
for
you,
this
Professor
this very elegant and simple and enjoyable presentation. Actually, I enjoyed the two presentations very much, and I think Professor Han and Professor Ashraf share me, and all the audience share me this feelings. Thank you very much.
Wonderful evening. Thank you very much, Professor Halawa, and all the audience were very enthusiastic to have the presentation, and we assure them that it will be soon on the YouTube. Don't worry. Thank you very much.
Thank you very much. Thank you.
Thank you very much. Thank you very much, sir.
Thank
Have a
you.
good night.
Bye-bye.
Thank you, Professor Faisal. Thank you.
Thank you. Good night. Good night.
Good night. Goodbye.